Hi doctors, welcome to Pocket Clinics. We are here to discuss today the management of bleeding in pregnancy and how these patients will come to us and how we can manage them by going just by the very regular algorithms. When we say algorithms, don't get confused by these big words. It's basically what you think first. Anybody coming with bleeding from the vagina in pregnancy, first thing what you think? You always think in terms of an abortion or you think in terms of an ectopic pregnancy. And if she's coming to me with an advanced pregnancy, let's say she's coming to me around 37, 38 weeks of pregnancy, I'm thinking in terms of placenta previa or abruption. These four diagnoses, all of you know from your time when you got into MBBS. So algorithms mean that what do we think first, what kind of presentation the patient has, and then we can always formulate a very simple method of taking care of these patients, right? So what we're going to do, we'll see what is the regular management of a patient who comes with let's say first trimester or third trimester of bleeding. So when a patient comes with bleeding in pregnancy, what are we thinking of? We are thinking of in the first trimester, we're thinking of a threatened abortion. She can be having pain abdomen and vaginal bleeding. She is around, let's say, 10-11 weeks of pregnancy. We think she could be aborting. She could be having an ectopic pregnancy also. That's also coming with pain and bleeding. But yes, she'll be coming with some signs. If she's ruptured the ectopic, then she'll be coming with some signs like giddiness, or she'll say that I'm having blackouts. You know, when I get up and I feel my head is spinning and aankhon ke aage andhera chha jata hai, doctor sahab, something like that she's going to say, right? So we may also have an ectopic pregnancy or hydatidiform mole. Now mind you, hydatidiform mole, when it presents to us, don't think in terms of passage of grape-like vesicles. That is a mistake. A molar pregnancy will actually present to you with only bleeding per vaginum, not with passage of grape-like vesicles, because you must understand the uterus. If you see, the uterus is having a very tight cervix, especially in young women who are getting pregnant, isn't it? So this cervix, which is so tight, and suppose there's a hydatidiform mole, you know, molar pregnancy, which has a lot of vesicles. So those vesicles, when they come out from the cervix, they will get crushed, they will get ruptured, and those crushed vesicles will come out with blood mixed watery discharge. So hydatidiform mole does not come with passage of grape-like vesicles. That's a very rare thing to see. Okay, but yes, she may come to you with excessive vomiting along with vaginal bleeding. So excessive vomiting happens with molar pregnancy because the HCG is very high. So yes, that can also be one reason. There could be some shared anatomical causes like polyps. You know, gynecology, you should always think of common vaginal tumors and cervical tumors, vulval tumors, which can always cause bleeding. It's not that she has to be pregnant to have a polyp or a vaginitis or a vulval polyp or a vulval ulcer which could be bleeding. So if she's bleeding from the vagina, yes, it could be pregnancy related cause, but it could be a gynecological cause also. So think of cervical polyp, cervicitis, severe cervicitis, vaginal or cervical tear, which can happen because of trauma, can be because of sexual trauma also. Now, third trimester cause, very important. Third trimester causes are the ones which we are worried about because the bleeding is severe in these cases. Even in a case of a ruptured ectopic pregnancy, we are mostly able to save patients very fast because we know that she is losing blood. But if we diagnose in time, mostly we are able to save patients. But in a case of a third trimester bleeding placenta previa, she can rapidly lose a lot of blood. So that's why be very careful of placenta previa and abruptio placentae. Now, classical is that in third trimester, when she's coming to you with bleeding, she'll come with pain, that is abruption, painless bleeding, that is placenta previa. Also, painless bleeding will happen in vasa previa. Of course, uterine rupture will be catastrophic kind of a presentation. It'll be like, you know, suddenly the patient will have a tearing kind of a pain in the abdomen. She'll start having tachycardia. She'll rapidly lose blood into the abdomen. And if it is a rupture uterus at home, we are just hoping that she'll come to you alive in the hospital. It can happen sometimes, but most of the times they'll have some pain before this rupture happens. So if she comes to you with pain and bleeding in advanced pregnancy, and she's having a previous cesarean section or a previous myomectomy or a previous hysterotomy, any surgery on the uterus, and now she's pregnant, she's coming with pain, abdomen and vaginal bleeding, think of a rupture also, or an impending rupture at least. All right, so don't get bogged down by the too many things which we gynecologists are throwing at you. You must think of at least placenta previa and abruption, because you're working in a clinic and you're seeing a patient coming to you, and you must think in terms of threatened abortion and ectopic pregnancy at least. All right. Yes, preterm labor also comes with pain and bleeding, isn't it? A patient having labor will have some bleeding. Show. The cervical plug comes out and there'll be some show, isn't it? So there'll be some blood mixed water discharge in preterm labor also. So these are things which you should keep in your mind. Chalo, आगे बढ़ते हैं. Let us see the gestational divide. Two distinct clinical protocols are there. Suppose she's coming to us for the first 12 weeks, or she's coming to us from 24 to 40 weeks. So first trimester bleeding, focus on viability and ectopic risk. That means if it is a threatened abortion, if it is a pregnancy which is in the uterus and the baby is going out and she's aborting, that is, focus on the saving of the baby if it is a threatened abortion, or it could be an ectopic pregnancy, first trimester. These are the two major diagnoses. We are limiting ourselves to the major diagnosis. So do the fetal viability assessment by transvaginal ultrasound. Serum HCG and progesterone also in a healthy baby will be high, levels will be much higher, and the ectopic pregnancy must be ruled out, and you must always have a high index of suspicion of an ectopic pregnancy. So first trimester bleeding, think in terms of patient having ectopic pregnancy, or having ectopic pregnancy, or having a abortion. Now let us see third trimester bleeding. Now third trimester bleeding, focus on placental integrity and maternal fetal resuscitation. So placenta previa and abruption, I told you, are the two major diagnoses which will happen. So you must do a fetal heart assessment, find out what is happening to the fetal heart, whether there is any fetal distress associated with the loss of blood, and maternal stability, arrange for blood. And if you're seeing a patient in a big hospital, call the specialist immediately, because with abruption and with placenta previa, many times you end up doing an emergency cesarean section. So what do you do? What is the first trimester immediate action protocol? What is that? Whenever the patient comes with first trimester bleeding, give her strict bed rest and immediate ultrasound to find out what is wrong with the pregnancy, whether it's an intrauterine pregnancy which is probably aborting, or if it is an ectopic pregnancy which needs a, if it is ruptured, it needs an acute surgical intervention. So look for threatened abortion, missed abortion, and of course ectopic pregnancy risk will always be there. Then clinical escalation, if the bleeding continues despite primary interventions, you repeat the ultrasound and refer immediately to an obstetrician for a further treatment and assessment, or SOS evacuation. That is, the patient is having bleeding, you've done your initial resuscitation. Always remember, any patient with bleeding, start a large bore IV cannula. Always 16 gauge is preferred. Sometimes in ruptured ectopic pregnancy, the BP is falling so drastically that we are starting 2 IV cannulas of 16 gauge each. So give a rapid fluid, arrange for cross match, and if the patient is actually losing a lot of blood, what you can do? Get O negative blood immediately. You suppose she's A positive, arrange for the A positive blood, let them do a cross match. But to save life, sometimes what you have to do is just quickly get O negative blood, because nothing is better than replacing the volume with fluids and then replacing the volume with a O negative whole blood, because that's the only indication of whole blood these days. Otherwise, if a person has anemia and you're treating anemia, then you give packed cells. But whole blood indications are very limited now, and we give for such patients who have come in shock. So O negative blood you can get much faster. You have to just send a request and call the blood bank officer that I'm sending a request, and release the blood as fast as possible if the O negative is available ready at hand. So do this escalation if the bleeding is not stopping. Now, what are the pharmacological interventions? First trimester she's having bleeding, and we are assuming not of ectopic pregnancy right now, we are assuming it's an abortion. So what do? Do you give tocolytics? Look, there has been a suggestion that we should give a tocolytic, isoflurane or duodenone. That is absolute nonsense. We do not relax the uterus. It does not help, especially if it is bleeding. Never do that. We never give relaxants. Okay, so that is a very good thing, because these are protocols which have been taken from famous books. I've got them for you, because a lot of people will say that try to relax the uterus. No, if there is bleeding, we don't relax the uterus. We treat the condition rather than relaxing the uterus. So she's having threatened abortion, we give support to the pregnancy. How do we support the pregnancy? That is progesterones. So yes, we will give progesterones. Where is that? See, natural progesterone. There is a drug called Lupigest, which is a trade name. Natural progesterones are best. You can give them intramuscularly, you can give them orally, but my favorite route is always giving it vaginally. But now she's bleeding, isn't it? If she's bleeding, I would best go for an intramuscular progesterone. I'll also give some ethamsalate. I can also give ethamsalate, which is going to reduce the bleeding, hemostatic agent, or I can also give tranexamic acid, right? And I will give some antispasmodics, but this is also really not required. We can also give her some simple analgesics also rather than giving antispasmodics. But I'm not saying, I'm not putting a cross onto it. I'm saying, okay, you can give antispasmodics for pain relief, but I'm not saying a relaxant at all. Absolute nonsense. Never give relaxants when a patient is bleeding. Okay, then sedatives, definitely. And this is our, yes, the cornerstone of our treatment. If a woman is anxious, she's bleeding, she's going to get very difficult to manage. So give her some sedation. You can give her some diazepam. Generally, my favorite is to give her some pethidine, and pethidine is an opioid, can cause some vomiting sometimes. So along with pethidine, we give some perinorm, or we give some phenargan. You know, you must have heard of this combination, pethidine and phenargan. Ye de do, ek laga do, usko aaram mil jayega, that type of thing. So yes, we are generally giving a sedative also. Now, what is the clinical triage of the bleeding before 12 weeks? So yes, physical examination, there is peritoneal signs of hemodynamic instability. So do resuscitation, what I told you, IV line, IV fluid, and prepare for surgical intervention, and think in terms of ectopic pregnancy. Yes, and presume ectopic pregnancy, do an ultrasonography to assess what is the method of doing the best diagnosis. Early diagnosis is the transvaginal sonography. But yes, I mean, you can do an MRI also, but MRI is a time consuming procedure. Only if you have a doubt, then we do MRIs. Otherwise, TVS is the best. If you think that it's an ectopic pregnancy, I told you if it's an abortion, what to do. But if it's an ectopic pregnancy, I must resuscitate and confirm my diagnosis quickly by a transvaginal sonography. Most hospitals at even 2 in the morning, they'll have a radiologist or they'll have a gynecologist. There'll be many machines, and immediately an ultrasound can be done. So don't worry about that. Get the TVS to find out whether there is a ruptured ectopic pregnancy. Now, physical examination you've done and you find out there's a non-obstetric cause of bleeding. Let's say there's a vaginal tear. Couple had intercourse, and there was intercourse after 2 months, and the vagina was dry. They had intercourse, and there was some small vaginal tear which is bleeding. Sometimes small vaginal tear, bleeding is excessive. Don't think small vaginal tears bleed a little. Vaginal tears can bleed torrentially. People have come in shock to my hospital with vaginal tears. All right. So yes, think in terms of some polyps bleeding sometimes, cervicitis, cervix is infected, and even intercourse can start that bleeding. Okay. And then products of conception, if they're visible on examination, that means it's a incomplete abortion. She has lost some products, and now there are some products left. You have diagnosed it's a case of abortion, and some bits are left. You'll do a DNC to take out the products. Patient are stable, no products of conception or other cause of bleeding identified. Perform a transvaginal sonography and obtain beta HCG levels. She's bleeding, but you don't see it's an ectopic pregnancy. She's bleeding, but you don't see there's an intrauterine pregnancy. You cannot see, but still she's bleeding a little bit. So yes, we are not very sure of the type of pregnancy it is. That can also be an issue. She's bleeding, but she's got a pregnancy test positive. You cannot see uterine pregnancy. You cannot see an ectopic pregnancy. Then you keep repeating the HCGs and you do the resuscitation. Of course, if there is mild bleeding, you don't really need resuscitation. It could be some spotting sometimes. Okay. So perform a transvaginal sonography and do an HCG level. Sometimes HCG levels help us. If the HCGs are doubling every 2 days, then a intrauterine pregnancy is coming up. If the HCG is not doubling every 2 days, then maybe it's an early ectopic which you are not able to see in the early ultrasound. Yes, if it is getting too complicated, ask the obs guys. The obs guys are known to help you, right? Call the obstetrician. It's not that you have to manage all the cases. You have seen the patient, and most of the threatened abortions you can manage. If it is an incomplete abortion, call the gyno. If it's a ruptured ectopic pregnancy, call the gyno, isn't it? They're supposed to help you manage the patients. Of course, your diagnosis as the clinician who is seeing them first is very important to know that yes, this is an emergency. Do the triage and get the gynecologist immediately. Wherever he or she is having his dinner, please tell him to leave and come immediately to the emergency because patient is in shock. Patient has come pregnant and there is only mild amount of bleeding. Give some progesterone injection, give her some sedation, tell the gyno that the patient has gone for ultrasound and you better be here in the next 15 minutes after the ultrasound is over. And then you see that there is some bleeding because of a small amount of vaginitis, tell the gyno to finish his dinner and then come and have a look. All right. So you do a triage and do the assessment, which will be the first clinician's first act of taking care of a patient. Right. So if you do an ultrasound and on the ultrasound you see that there is a viable intrauterine pregnancy, the patient has come with early trimester bleeding, there is a viable intrauterine pregnancy, means live pregnancy, that means it's a threatened abortion, do a treatment. And if there is a non-viable pregnancy, that means baby is dead, then you will have to do a treatment for early pregnancy loss. Of course, the gyno will do a DNC or may also do a medical abortion. That is, we can give some mifepristone and misoprostol. We can do that also. But that leave it to the gynecologist, because if it is a non-viable pregnancy on the ultrasound, then the gynecologist should be doing his job there, because non-gynecologist doctors are not supposed to do MTP. So you'll have to involve the gynecologist here. Then intrauterine pregnancy and the viability is uncertain. Then repeat the transvaginal sonography on a weekly basis and you'll find out whether the baby is going to make it or not. No intrauterine pregnancy or there's an ectopic pregnancy. I've already told you the management of an ectopic pregnancy, right? That you'll have to find out whether the pregnancy is definitely seen in the tube or not, and if it is seen in the tube, then you have to manage with the gynecologist. If it is not seen in the tube and if it is not seen in the uterus, then you do serial HCG levels. Right. Now, third trimester, if there is bleeding, I told you there can be abruption, there can be placenta previa as the cause of bleeding. So, if there is third trimester bleeding, so what is the placenta previa abruption management? Pharmacological protocol, give hemodynamic support, that is the resuscitation. Always the dextrose normal saline or ringer lactate rapidly is given, to IV cannulas are given to rapidly infuse fluids, and you can give a hemostatic agent like ethamsalate or tranexamic acid. So, bleeding can be managed. Any bleeding, any place in the body, we are nowadays giving a lot of antifibrinolytics like ethamsalate and tranexamic acid. Now, you will also give sedation for both cases, if it is an abruption or if it is a case of a placenta previa. Both cases sedation is given and rest is given, but tocolytics are not given. Let me get that even more starkly told to you. Please do not give tocolytics. Again, tocolytics are not to be given when there is abruption or placenta previa. Nonsense. So, these are the things which are not to be done. A lot of people do this and end up, they burn their hands by giving tocolytics, and the bleeding actually increases with the tocolytics. In fact, it's a contraindication to give tocolytics, especially if a patient is in placenta previa bleeding and has also gone into labor. You're going to increase the bleeding. All right. So, don't give that. So, yes. Antepartum hemorrhage, decision making matrix. So, resuscitate and always do a diagnosis by an ultrasound. Help your diagnosis with an ultrasound. Painless bleeding PV, an ultrasound shows a placenta previa. Then, if it is less than 37, if it is more than 37 weeks, go ahead and do a cesarean section. Of course, the obstetrician will do, but I'm making you understand the urgency by which you should be referring the patient to the obstetrician. Now, if it is 34 to 37 weeks, we can still do a cesarean section, because 34 weeks is when the lung maturity is done. So, if there is a patient with placenta previa and the ultrasound is very surely showing that there is bleeding because of placenta previa, you can take a baby out after 34 weeks. It is preterm, we know that, but the lungs are mature. So, less than 37 weeks, but after 34 weeks, lung is mature, you can take out. But rarely before 34 weeks if the patient is bleeding. If it is before 34 weeks and placenta previa is bleeding, conservative treatment can be done. Of course, the obstetrician is the best person to take care of that. It is known as the McFee. It is known as the McFee-Johnson regime. McFee-Johnson regime is the one where we say rest and sedation, resuscitation of placenta previa, and 90% cases the bleeding stops. But yes, under the obstetrician's care in the high-risk ward. And the bleeding stops after 24 hours. I actually shift the patient to the ward. She stays in the ward for another 24 hours. If the bleeding is not there, she goes home and we call her after next week to the OPD. So many a times, a case of Placenta previa, the bleeding will actually stop. So yes, we do this only before 34 weeks, the conservative management. Now, the patient is having painless bleeding previa. Ultrasound shows no placenta previa. Be careful, huh? You do the ultrasound and you see there is painless bleeding, the patient has come to you, and there is placenta in the upper segment, no placenta previa. Think in terms of vasa previa, vessels on the internal os. So sometimes the cord of the baby is naked. Okay, there is a naked cord. That means the umbilical cord which is attaching to the placenta, this umbilical cord has the vessels already exposed before they reaching the margin of the placenta. So this baby can break his own umbilical vessels and cause the bleeding. So that is what is known as a vasa previa, vessel on the os. What is placenta previa? Placenta on the os. That you know very well. Placenta previa is placenta on the os like this, and you see the fetus here. Placenta on the os, and here the mother is bleeding. Placenta previa, it is maternal bleeding. But vasa previa, it is fetal bleeding. It is double the emergency, guys. Baby is bleeding means the baby is going to die very fast. Baby has only 300 ml of blood, 100 ml per kg. So vasa previa presents very similar to placenta previa. Painless bleeding, but on the ultrasound you see the placenta is upper segment. So you confirm the diagnosis of vasa previa by doing the apt test. Of course, the gynecologist will do it, and if it is positive, then you do a cesarean section for the saving of the baby. Now, painful bleeding, PV, it is an abruption, and in that, if the fetus is normal and there is no distress, you can do a normal vaginal delivery. But if there is fetal distress and abruption, you can do a cesarean section. But there is no conservation. There is no conservation in a case of abruption. Even if it is coming to us, before 34 weeks, even if the lung is not mature, conservation is done only in placenta previa. In abruption, we never do a conservation because the conservation is a problem. In abruption, the placenta has separated a little, and the clot inside can cause DIC. Because DIC can happen in a case of placenta previa, that's why we never do a conservation in abruption. I don't know what I said just now. I hope I said abruption. There is no conservation in abruption because it can cause DIC. All right. Chalo. So after understanding this basic algorithms of managing bleeding, let me just do an exercise which is very interesting. We will just do all of this understanding with the AI prompt. Let's see. Let's ask Gemini how we can manage a case of bleeding. Okay, let's see. I'll stand on the side so that you can see what discussions I'm having with Gemini. So I'll ask Gemini how we are doing the management of bleeding. I got some questions already made, so I'll just write it here and show you. Okay, so the question is, I'm reading the question for you. So the question is, hey Gemini, play the role of a patient walking to OBGYN OPD with vaginal bleeding in pregnancy. You can presume the role of any possible diagnosis for this complaint, bleeding in pregnancy. I will be playing the role of a doctor attending to you. When inquired, answer as per the role you are playing. Keep the physical examination findings and lab reports ready and present when asked. Shall we begin? So I have already kept the question prompts here for you so that we are trying to see how AI is helping us in the diagnosis. I've already told you the basics. Let's see if AI has all the data from so many doctors across the world, and are these the correct methods of managing, and how do you manage things? So yes, when I'm putting this, let's see what AI is telling us to do. Yes, doctor, we can begin. I'm really worried about this bleeding. Please go ahead and ask your questions. So what are the questions I'm going to ask her? I'm going to ask her, well, she's having bleeding in pregnancy. First, we always say, how long has your bleeding been? How long has your bleeding been? So I'm going to write that. How long have you been bleeding? So let's see. Okay, it started this morning around 4 hours ago. Onset was sudden, a few tablespoons, color was bright red. What should we do next, doctor? See, this is how you go about doing things. Okay, I'm going to ask, was there any predisposing reason? Was there anything you did which could have started this bleeding, like physical activity, lifting heavy weights, or somebody brushed against your abdomen, or you had intercourse? So we are going to ask that. It's happening live in front of you. So how does Gemini help? No, doctor, I was just sitting on my desk working. I was just no recent intercourse, no falls, no trauma. See, whatever I was telling you, the I didn't ask. I just said, did you do anything which could have caused this bleeding? And what I told you, Gemini is already telling me as an answer. No, there was no activity. I was just sitting. There was no trauma and there was no intercourse. So what is the next question I'm going to ask? I'm going to ask, okay, fine. How much is your pregnancy today that you come with bleeding? How much is your pregnancy? So the doctor is asking the question, Gemini is asking, sir, I'm 14 weeks pregnant now. Last period was 14 weeks ago. Ultrasound confirmed this date earlier on, and this is my first pregnancy. Then the next question is, do you have any pain with this bleeding? She's at 14 weeks. If there is any pain, of course, we're thinking in terms of her abortion now. So do you have any pain with this bleeding? And Gemini answers, let's see, no doctor, I don't have any pain or cramping at all. Absolutely none. Cramping, no tightness in my belly, feeling just very anxious about this bleeding. So yes, if there is no pain and then there is bleeding, then it could be threatened abortion, or it could be also be a case of a incompetent os. Okay, that also abortion because of a cervix which is very short and very loose, that can also come with painless bleeding. So did you have any tissues coming out of the vagina when you came to the hospital? That means I'm asking leading questions. Are you in the process of abortion? So what does Gemini answer? No, doctor, I have not passed any tissue or clots and just fluid blood, and I changed one pad when I came. So let us examine. So your blood pressure is quite low, let's say 74 by 40, and pulse is 128. Are you feeling giddy? Now, I'm just asking whether she's actually bled a lot before she came to me, or could she be having a ruptured ectopic pregnancy? So let's see what Gemini answers. Yes, doctor, I feel very dizzy and lightheaded. Right now, my heart is racing. Okay, so let us see. I can see the external os is open and some tissues are still felt through the cervix. Your uterus seems a little small for the pregnancy duration. These are my findings. So I'm saying that I have seen the cervix is open, there are some tissues felt, and she is having a uterine size which is little small for the period of gestation. For 14 weeks it should be size of a grapefruit, but the size is looking smaller to me, like the size of an apple. So I'm seeing what diagnosis it is helping me with. Oh no, does that mean I'm losing my baby? Hearing that the service open and things are stuck makes me feel so scary, especially since I've been feeling so dizzy. Based on my clinical case design, your physical findings confirm an incomplete abortion. All right, patient status update, emotional status, highly anxious, tearful, and terrified of losing the pregnancy. Physical state, markedly weak, pale, and struggling to stay conscious. Okay, so lab reports and diagnostics. Since you have examined me and found me to be hemodynamically unstable, my laboratory and emergency data are now unlocked. Please ask for lab reports, blood work, or your emergency resuscitation and management plan. Like you give IV fluids and IV line, and you arrange for blood. All of that is being told, just like we discussed in our management. So yes, your blood work shows anemia, and I must manage this as soon as possible. What do you suggest is your best treatment of incomplete abortion? I'm hoping that they'll say curettage or a DNC or a evacuation. Okay, I'm hoping that AI is going to say that. I understand I'm losing the pregnancy, doctor, and want to make sure I'm safe because I'm bleeding heavily and open cervix and I'm in hypovolemic shock. The best and most urgent treatment is immediate resuscitation followed by surgical evacuation. All right. So, IV line, fluids, blood, oxygen, and procedure of uterine evacuation via surgical management. Method is uterine aspiration, manual vacuum aspiration, dilatation, and curettage, just like we discussed. So, yes, that was a role playing done along with Gemini to tell you that all of what we've discussed are these standard protocols, and these standard protocols have been fed into AI, and that's why AI also can help us. So sometimes you can try out all these clinical situations and make your own algorithms on Gemini, right, guys? So I hope is this okay? Oh, there are so many. Oh God, I missed out totally on you guys. You were okay. Let's see what you guys have been asking me. Okay, there were some for us. Okay, so the Prasmanta, so nice to see you, man. Long time. Okay, second year students, good evening, sir. And PV examination is contraindicated every case of vaginal bleeding? No, not at all. If you know that the patient, yes, if you know that the patient is a case of Placenta Previa, you have an ultrasound, then it is contraindicated. We never say that it is contraindicated for other cases. Sometimes the PV will help you in the diagnosis. Okay, it's only if you know it is a case of Placenta Previa. Okay, love you, sir. Thank you. Love you too, buddy. And third trimester, okay, fine, all of these can be there. Yes, McFee-Johnson management regime. And what else you guys are asking me? Is this for PG preparation also? Yeah, obviously, Om Pathak, this is how we prepare for life as obstetricians. So yes, in post-graduation also, you're going to get similar situations in your exam. Good, excellent lecture. Thank you so much. Is the delayed cord clamping in active? I can never get out of this, right? ओके यस गाइस वेरी गुड कोई मौका नहीं छोड़ो पीजी एंट्रेंस की तैयारी करने का तो यस भाई हम लोग इंडिया में करते हैं डिलेड कॉर्ड क्लैंपिंग अब रिमेंबर द थ्री कंपोनेंट्स हैव नॉट चेंज WHO ने कुछ लिखा है हम जानते हैं दैट इज जस्ट कम अराउंड 2 months बैक सो वी आर नॉट गोइंग टू इमीडिएटली इंप्लीमेंट यू गो टू एनी हॉस्पिटल इन द कंट्री एनी गवर्नमेंट हॉस्पिटल एंड इवन द बिग प्राइवेट हॉस्पिटल्स yesterday we had a discussion I think yes 2 days back where we had a discussion or the 50 predictor questions. Please see that on PW forum we've done. Predictor FMG 2026 June 2026 June Prassan Vij you put on YouTube will get. So we've discussed all of that there. So please understand that WHO has given us some updates, but those updates do not become implemented immediately. So yes, they say delayed cord clamping is in because WHO says that. We also say that delayed cord clamping is in because our children will gain by 1 gram of hemoglobin if you delay it. But what are the three main components of active management of third stage labor? Those have not changed, and those are oxytocin, control cord traction to remove the placenta, and uterine massage. They have not changed. So yes, we are going to stop this lecture. Extended discussion now we can do because my students will always ask me about active management of third stage of labor. So here is it for you. We can see this once again. Okay, so this is what is the active management of third stage of labor. You can see first thing is injection oxytocin. This is Ministry of Health and Family Welfare. It is there in all the hospitals in the country. You're supposed to have it in front of all the medical colleges and labor room of all the medical colleges and first response units and even in district hospitals. Injection oxytocin, control cord traction and the uterine massage. You have to do uterine massage, and this is Ministry of Health and Family Welfare. And then what I'm showing you something here. See, there is something written here. If you can see my marker here, you know, in small font. I'm just showing you, highlighting it in the next page for use in medical colleges, district hospitals and first response units. And this is from a private hospital in the country, and that is again saying oxytocin 10 units, control cord traction and uterine massage. Then there was this question, yes, this question which came in INI-CET, I think 2 years back. Arrange the sequence of third stage management. Check for second baby, oxytocin, control cord traction and uterine massage. So these are the 4 things which you do for the active management. So put them in the correct order. Obviously the order is A, B, C and D. Now my impetus is on this uterine massage. If INI-CET is asked you that where do you do the uterine massage in active management of third stage of labor, that means we are doing it. That's why we are asking you this. Where is uterine massage done? It is done as the last thing after the delivery of the placenta, obviously. So uterine massage is done. That's why they're asking you guys, not because you don't have to do it. Come, I'll show you one more thing. This was a conference in November in Delhi. It was organized by the Lady Hardinge Medical College. The head of the departments were there from all the major hospitals of the city, and yours truly was also one of the invited head of the departments. And we discussed for PPH management one complete day, and this was the slide which was shown repeatedly. Active management of third stage of labor, oxytocin 10 units, control cord traction, uterine massage. Carbetocin is a recent entry, we also know that. So WHO is a respectable body, all of us know that. They are doing so much of work, they give so much of directions, but they do not become implemented immediately into our system. We are not waiting, जैसे WHO ने बोला बस टाइप करके डाल दो, सारे पोस्टर लगा दो, ऐसा नहीं होता भाई. Ministry of Health and Welfare has to see what we are good to implement. WHO is saying, you know what, PPH definition, if the blood loss is more than 300 ml, but along with blood pressure less than 100 systolic, that is also significant. Agreed, that's a very good definition. You know what is the blood pressure of most of women who come to the OPD in obstetrics, pregnant mothers especially? 94/74, 98/60. And we just see them and send them home. उनका पहले ही blood pressure 100 से कम होता है. Most of women are, thin women who are average nourished, and they have low blood pressures with which they are running their life comfortably. So they are having PPH even before delivering. What are you going to say then? So please do not just blindly follow what recommendations come. The recommendations have come, I've given you them, but they have not been implemented in any of the hospitals so far. Right? Hello guys, good. You took this opportunity to discuss PPH once more. Good evening, I'm Ben, 5 years MBCHB in Uganda. Can we still give Dufaston? For Dufaston, for threatened abortion, or for abruption, or for Placenta Previa. If you're asking about that, so Dufaston is a progesterone, and progesterones can be given, and they must be given for the first trimester bleeding, sometimes even in second trimester, that is around 12 weeks to 24 weeks, 26 weeks, we do give Dufaston. It is a oral type of a progesterone, so definitely it is given, but not for pregnancy related bleeding, which is abruption and placenta previa. Definitely we have to give progesterones, but I'm not a very happy advertiser of oral progesterones. I'm not anti-Dufaston, that's a trade name you've told. It is dydrogesterone. If I say Dufaston and if I say I'm not giving it, my friends who are selling Dufaston are going to get angry with me. So I'm just saying that I'm not a very good user of Dufaston, because that is dydrogesterone, and oral progesterones, I feel they give a lot of side effects. You can give, definitely you have to give some progesterones. It can be oral progesterones like you're asking me, it can be intramuscular progesterones as well, and when the bleeding stops, we can start the vaginal progesterones, which is the best. Always vaginal progesterones are the best. Right, so instead of progesterone, so Dufaston is a progesterone, my friend. Dafaston, you're right, it is actually Dufaston. That is actually a progesterone. It is dydrogesterone. It is a progesterone. All right. Right, guys. So that was nice talking to all of you, and I hope some insights into bleeding in pregnancies have been learned today, and we shall keep discussing these pocket clinics, short topics as and when the requirement comes up. All the best, guys, and those PG entrance and MCI entrance students, we are meeting again for the marathon on 24th, so we can always discuss our questions there. Right, guys? Sir, हिंदी में बोलिए please. अरे मैं हिंदी तो बोलता हूँ यार. Thank you so much, Average Medical. You are rating my lecture. So nice of you. If you're writing the exam, I hope you get 300 out of 300. Thank you, guys. बहुत अच्छा लगा आप लोगों से इंटरेक्शन करके. मुझे उम्मीद नहीं थी कि आप लोग इस लेक्चर के लिए आएंगे, बट आप आए तो हौसला अफजाई के लिए धन्यवाद, और जल्दी मिलते हैं 24th को जब हम मैराथन पे बातें करेंगे. बाय गाइस, गुड इवनिंग.